Good afternoon, everybody. Thank you for joining me today, and thank you for your availability so we can talk about the latest and greatest in coronavirus here in Monroe County. We've been getting a lot of questions about testing, so I wanted to spend the majority of our time talking about that. As you know, testing, tracing, and isolating are the three major functions of the health department in this phase of a pandemic, and so we take testing and tracing and isolating very important. And it all starts with testing. And so I think it's very important for you all and for our public to understand who should get tested, how to get tested, why to get tested. But the most important feature of a test, and this is true every day in medicine as well, is that when you get a test, the most important reason to get the test is that it will change what you do. There are a lot of features of this test that are still, unfortunately, falsely reassuring and falsely alarming. And so we want to make sure that people understand the meaning of tests, and the meaning of tests can be very confusing. So I want to spend some time talking about that. But first of all, let's talk a little bit about the question of how long it takes to get a test. So as you all know, as of July 1st, the State Department of Health has opened up testing essentially to all New York residents. And so we are seeing an increase in demand. Our capacity to test has to date remained adequate, although what we are seeing is select pockets of where it is taking a little longer than it had been. In general, it's taking 2 to 3 days for the majority of tests to come back. But as you know, there is significant variation in the test processing time. And that has to do with a number of factors. One of those is where the lab is drawn, whether it's in a hospital setting or in an outpatient setting. Another reason is the clinical indication. So if somebody is being admitted to the hospital, their lab is being drawn typically in the emergency room or when they arrive on the floor, and that test is processed on site, and so that can take only hours because the clinical indication is relatively urgent to understand if somebody's COVID positive or not when they're being admitted to the hospital, which is in contrast to other sites, for example, at MCC. None of those patients generally are on their way to the hospital, and so those tests can take longer. So there's a number of reasons for the variation in that, but in general, though we do see some outliers, the vast majority of tests are being done within 2 to 3 days. Currently, our number of tests is well above 1,000, and you'll recall one of the metrics for the reopening of our community in the phases was that we needed to have 30 tests per 1,000 residents per month. And so when you do the math, that comes down to about 740 tests per day for Monroe County, and we're well in excess of 741. So that is not a concern at the moment, but we certainly want to do the best we can and increase testing capacity as much as possible. So again, anybody can get a test. We in healthcare are still wanting to prioritize tests for people in whom the result will make a major change in our management. So we certainly want to know in people who are symptomatic, people who are high risk, older adults, individuals with chronic medical concerns, any children who have symptoms or who may be at risk for the multisystem inflammatory syndrome, which we have thankfully not seen very much of lately, which is good. People who are getting surgery, people who are being admitted to the hospital, people who have been in close contact with someone who is a known positive. Whether they have symptoms or not, we're going to want to test them because we know they have a higher chance of having a true positive result. Anybody in quarantine, healthcare workers, first responders, the same groups that we had been prioritizing in the past. Anybody who's an essential worker who interacts directly with the public, and so forth. So when is the right time to get tested? And this gets into the question of how do we interpret these tests? So without getting too far into the clinical epidemiology weeds, tests aren't perfect. And when you have a negative test result, that doesn't necessarily mean you don't have the target condition. When the test result comes back negative, and we know that you don't have the target condition, we call that a true negative. But unfortunately, when it happens, and it happens relatively commonly with COVID, that you get a negative test result, but you later end up having the illness, we call that a false negative. And the challenge with the tests available today in diagnosing COVID-19 is that there is a significant false negative rate. And we'll get into those numbers. But the implication of a false negative rate, false negative result, is that the person who's taking the test may derive a false sense of security. And when they have a false sense of security, they may be inclined to relax on the precautions that they might otherwise take had they not known that they had a negative result, or had they not gotten tested at all. And that is of significant concern to us in public health, because the safety of this community rests upon everybody taking precautions. And we certainly don't want to give anybody a false sense of reassurance, particularly one that might lead them to stop taking the precautions that we so desperately need to rely upon in order to keep one another healthy. So to give you a sense of the quantity of the false negative rate, so a couple statistics. First of all, when a person becomes symptomatic, if they become symptomatic from this virus, on the day they get that those symptoms, the false negative rate is still 38%. So 38% of people who are symptomatic on day one of their illness may still have a negative test result. When we wait 3 or 4 days later, it comes back positive, and then we can extrapolate backwards and we can conclude that the test that they had on day one of symptoms was a false negative. So as you can imagine, it's not a perfect test, even when you have a confirmed infection. We know that the test performs the best 8 days after the onset, or 8 days after the person gets infected. And that sounds like a long period of time. Again, some people may or may not get symptoms, but that is the date on which the test is most likely to be reliable, i.e. still have a higher true positive rate and the lowest false negative rate. So to keep a long story short, the point of this is, please do not be falsely reassured when you have a negative test result. A positive test result is also somewhat confusing, because we know that many people who have this infection have an asymptomatic course. When you have a positive test, it doesn't mean that you're infectious today if you're asymptomatic. If you have a positive result and you're symptomatic, it's highly likely that you're currently ill, currently contagious, and at greater risk for spreading the infection. But because so many people have an asymptomatic course, and because the test can remain positive for 6 to 8 weeks, you can get a positive result long after you've cleared the illness from your body. And so that is the other confusing part about a positive test. The other question that often comes up is, if I'm under quarantine and I get a negative test result, does that mean I can come off of quarantine? And the answer is no, because what determines your status on quarantine is your exposure to a high-risk contact. And we need to wait the 14-day incubation period from the date on which you contacted that person to ensure that you've gone through the period of when you would be expected to be contagious and possibly have symptoms. And so having a negative result does not necessarily mean you are free to move about the county. So a question that often comes up is, how often should you get tested? You could get tested every day. The reality is that we don't have the capacity for that, and there's really no good reason for that, but there's really nothing stopping you from doing that if you're able to get tested every day. Realistically, what we tell people is, if you really want to know, every week is more than adequate. Healthcare workers, people who work in nursing homes, essential workers, and so forth, testing every week is currently the recommendation for how frequently to get tested if you're at high risk or have high concern. And then as far as how long it should take, 2 to 3 days is the typical average. But that being said, we've seen examples of 10 to 14, sometimes even longer. And that typically results from having the specimens sent out to what we call a reference lab, which is typically out of state. So with that, I will pause and take questions. Maybe I can do that. Oh, there. All right, I'll unmute you.
Did you talk? This is Berkeley Breen. Did you call my name? I was unable to hear you.
Yes, we did. Berkeley.
Okay, sorry. Okay, so Dr. Mendoza, about a half hour ago, Governor Cuomo explained some of the delay here in getting test results. And he said that had mostly to do with tests that went to national labs. About approximately 30% go to national labs. What percent of the tests in Monroe County would go to national labs?
So I don't have that statistic on hand. In order to gather that data, because the lab location is not available as a downloadable field in the data set, the only way to get those data are to go through each result by hand, one by one. So that is not a statistic I have off the top of my head.
Okay. And I'll just ask my follow-up now, if you don't mind, get it over with. The question was, if someone gets a test and the result comes back several days later and that person is notified that it's a positive test, when does the 14-day quarantine start? When the test was or the sample given, or when the notification is made?
So this is a good opportunity to highlight the difference between quarantine and isolation. So the quarantine period begins on the day that the individual had the high-risk contact with a known positive case. So irrespective of when the test result comes in, the duration of quarantine is 14 days. If that person tests positive, then they're a case, then they become isolated. Their isolation period is 10 days from the date of the positive test if they're asymptomatic, or 10 days from the date of their onset of symptoms, whichever came first. They remain under isolation for 10 days as long as the last 3 days were fever and symptom free. If at the end of 10 days they continue to have fevers and symptoms, their isolation period will continue until they have 3 days of no symptoms and no fever.
Thank you.
Oh, I have to do the thing. Jane, oh, you're unmuted, yeah.
Oh, I can't hear whoever is selling the names. I can't hear you at all. So sorry for the delay. But Dr. Mendoza, I had a question about, we've noticed that the number of females who are testing positive in their 20s is higher than any other demographic. Is there any reason why?
Our conclusion is that there are more younger people traveling and more younger people gathering. They tend to be more female than male. I'll have to look at the numbers, but I believe there are more females than males in that age group. I don't think there's anything in particular about being male or female that predisposes one more or less to the infection. I think it has more to do with the propensity toward travel and gatherings that explains why that demographic is now the leading demographic in terms of positive cases.
Okay. And for the number of people who have been getting false positives, can you talk about that?
So we don't see false positives. When it comes to the PCR test, the false positives are relatively rare, except when we have an asymptomatic case who gets tested positive later. The challenge with those positives is that we can't yet conclude that they're false positives because we don't know that they were positive, that we don't know that they were not positive before. So we have to assume that those are true positives and take all the proper precautions, put them under isolation and so forth, even though we understand that it's possible that they may have acquired the infection weeks or months ago, and they may have a persistently positive test. So false positives are a lot less of a concern than the false negatives.
Okay, thank you.
Thank you. Patty Singer from Minority Reporter is next.
Hi. So the testing, as you said, is confusing. Should everybody get tested regardless of their high risk exposure, or even if it seems confusing to them about why they should do it? I mean, what's your bottom line here with all the confusion around the testing and the results?
My bottom line is get tested if it's going to change what you do. That's the bottom line. Now, if you have symptoms, we definitely want you to get tested. If you work in a profession where you are at risk of exposing other people, we certainly want you to get tested. But for anybody outside of those circumstances, I think it's fine to get tested. It's not unlike getting tested for other communicable illnesses. It's never a bad idea to get tested. My only caution in this case is that that people understand the meaning of the result when it comes back. Typically, the negative is the one where we want people to be clear on what that means because of the false negative chance. But there's certainly no harm in getting tested.
Have things changed, or have your opinion changed about the antibody testing? Has that become something that is more accurate now and helping us know what exposure has been throughout the community?
No, unfortunately, my stance on that has not changed. Certainly the hope will be when the antibody test is more reliable that we will be able to interpret it as a sign of immunity. But as with before, the science on that is still not quite there yet.
So if someone had negative antibody test, that's not a definite that they haven't been exposed, or if they have a positive, it's that they have been exposed?
A negative test is pretty reliable as an indicator that they have not contracted the COVID-19 virus, yes. But a positive, there's still some debate about that.
Okay, thank you.
Thank you, Patty. Next up is Philip Boudreau from Spectrum, followed by Brian Sharp at the Democrat and Chronicle.
So basically, is this press conference just a call to action, the call for more people to get tested for the coronavirus?
It's a call to action to understand what testing means. Certainly if people want to get tested, I would encourage that. But more importantly, I want them to understand why and how to interpret the result. Yeah. Because we've been getting a lot of questions about should I get tested, and the delays and so forth. And I just thought it'd be a good opportunity for people to have that opportunity to understand. And
just to change the topic a little bit, when it comes to the PPE requirements, how is Monroe County doing on that as we approach the fall and with school reopening?
Right now we're doing very well. We have adequate PPE in our supply. We're working with the school districts and universities and the public. But at some point, all of our businesses and all of our schools will have to begin to obtain their own, and many already have obtained their own PPE. So that hasn't really been an issue of shortage lately.
Thank you.
Thank you, Philip. Brian Sharp from the Democrat and Chronicle. Next up will be Will Astor from the Beacon.
So, Dr. Mendoza, when you talk about being able to interpret the results correctly, I'm just wondering, because I hear a lot of parents say, well, I'm going to get tested, and then if it comes back negative, we can have a play date with our kids. Or I'm going to get tested, and if it comes back negative, I'll go visit my elderly parents. What would you say to those folks when you say they need to know the 38% to understand it? What would you recommend then that they do if they get the negative result?
I would do nothing different. The point here is that a negative test is not reliable enough for anybody to stop taking the precautions that we all need to keep the entire public safe. So that false sense of security, that false reassurance is really what we want to avoid. And you can't get tested enough. We will always have that chance of a false negative. Until you're positive, there's always a possibility of that false negative. And anytime there's that possibility, we are at risk of spreading the infection. What is allowing us to proceed as relatively well as we can be is that we have a low prevalence rate in this county relative certainly to the rest of the country. And that is due in large measure to our collective ability to keep these precautions going. At the moment we stop, we start letting our guard down, that's when we put ourselves at risk for sliding backwards.
And then I just wanted to clarify on the 38%, is that the relative, does that relate to the nasal swab, the more invasive one, or because there's also, I guess, a less invasive, I don't know if it's a mouth swab or whatnot. I think RGH was going to compare and contrast and see if they came out equal. I'm just wondering, do you know, is there a difference between the two, or is that sort of throw everything into one pot?
The data I cited to you was from a study that Johns Hopkins published that looked at the nasal pharyngeal PCR test.
Okay, thank you. Mm-hmm. Do you know, by the way, about the other one, how often those are negative? False negative?
The false negative rate ought to be higher on those. We don't know how much, but whenever you have an oropharyngeal or a saliva test, assuming the same other technology on the back end, the false negative rate will be higher.
Okay, thank you.
Thank you. Will Astor from the Beacon, followed by Jeremy Mule from City Newspaper.
Okay, Dr. Mendoza, could you clarify, is testing available on demand from any site for anyone at any time? Or are there only certain sites? I ask because I have a 90-year-old friend who was trying to get tested, talked to his doctor, talked to his insurance company, went to Unity, and claims he was turned away. And I see at various sites, they say only certain people. So could you clarify who can get tested where and when?
You know, we have a website on the county, we have a web page on the county website that will show all the sites where you can get tested. What happens when you get there really is at the discretion of the clinician who sees you. In some clinics, they don't have the ability to collect the test. Primary care offices may not have those, although the vast majority will. But when you look at hospitals and urgent cares and those sorts of sites, it really is at the discretion of the clinician who sees you. But everybody is eligible. As long as you can find a clinician to order the test result, anybody can have the test obtained. When you go to the MCC site, there's an online interview that you can complete, and essentially anybody can get tested there as well.
Okay, and could you give a picture of what the capacity is for, are there any questions about supplies available?
So when there are delays, that typically has to do with currently the reagents, the chemicals that are necessary to process the result, the specimen. The specimen is collected on essentially a Q-tip and put into a liquid into a vial that's sent to a lab, and then the lab does processing. There are several steps to that, but they all involve chemistry and chemicals. And as of late, those chemicals are what are in short supply. Earlier in the epidemic, the swabs, the test kits, were what we were experiencing a shortage in. So, you know, it tends to go back and forth, but whenever there's a shortage in those supplies, you'll see the processing time go up.
Thank you. Jeremy, you're up next, and Randy Gorman from WXXI will be standing by.
Thank you. Dr. Mendoza, a while back, I had asked about the numbers for the people in their 20s. And one of the things you mentioned is that they were higher because of a lot of them were frontline healthcare workers. Is that still a factor, or is it really what we're seeing now is the, as you put it, traveling and gathering?
We are still seeing some healthcare workers, but when you look at the 20s and the 30s, that tends to be the travelers and gatherers.
Great. Then I'm going to use myself as an example here. I've been tested for COVID a couple of times, had the swab stuck up my nose, and it's as delightful as everyone says it is. Not symptomatic, just doing it for, my own benefit, for the people around me. Didn't change anything that I did after I got the swab. Still wearing a mask, washing and sanitizing my hands, all the stuff you guys have been telling us to do. What should someone like me be doing after they get a test?
I would do all the things that you did right before you got the test. I guess I would say don't change anything.
Treat it like you didn't get a negative result at all, and you're
Correct.
Just going about life.
Correct.
Okay. Very good. Thanks.
Mm-hmm. Thank you.
Randy, you're next, and then Violet Woods from the Zone.
I am all set. Thank you.
Thanks, Randy. Violet, do you have a question? All right.
Still mute. Violet, are you there? Maybe not.
Okay, let's move on. Jack Watson from WROC.
Hi, Dr. Mendoza. Thank you for taking our questions today. Just want to ask about, we're tracking the virus in our community. Obviously, numbers looking relatively good right now. Schools can sometimes mean a convening of thousands of people, young people and adults. Would you say that at this point right now, it is practical to be reopening schools come August?
So there's a lot of time, believe it or not, between now and August. It may not feel like it, but the schools are working feverishly to pull their plans together. I know that some of the schools have released their plans. Is it practical? Yes, it is practical. Is it easy? Absolutely not. Will they be opening as though it was February or January? January? No, definitely not. But that's sort of the easy part. You know, the guidelines have been published. The schools are working to develop a plan. These plans represent their best effort to merge the guidelines with what's practical. And the practicality varies based on the district, based on the building, based on the number of doors and the width of the hallways, and a whole host of details that vary from building to building and classroom to classroom. And so it is practical, but it won't be easy. Am I nervous about it? Yes. Because we certainly don't want to see our community slide backwards. Do I know that there are risks to remaining closed? Yes. This is not a zero risk situation. And we have to balance the risks and benefits in a very nuanced way. To those who say reopen the doors just like it was in February, fail to understand that that is not necessarily safe. But to remain locked down as we were in March is also not necessarily safe, because there are a whole host of risks that we don't see that are happening because our kids are not interacting with one another, with their schools, their adults, and learning, and so forth. And there are a whole host of health benefits, of course, when people stay locked up inside. So we've got to be looking at this as a community, in a very nuanced way.
And just as a follow-up to that, higher education as well, we've got thousands of college kids who are coming from out of state to our area at schools like U of R, RIT.
Mhm.
Do you see, and obviously 31 states out of the 50 now are on the state's 14-day quarantine list when you travel here from one of those states. Do you see our state eventually having to make all travelers quarantine when they come from out of state?
I look at travelers in relatively the same way, whether you're coming from, Batavia or Alabama. Anybody who's coming into our region has the potential of spreading the infection. And there are people in these high-risk states who are low risk, and there are people across the border in other counties here in upstate New York who are high risk. So as I see it, everybody who's coming in ought to take precautions. Those who are from the high-risk states have, by the governor's directive, the requirement to quarantine for 14 days. But anybody who's high risk ought to be quarantining for 14 days, no matter where you're coming from. Because the reality is that importing a case from another location, whether it's out of county or out of state, stands to put our community back at risk. So when I look at the prospect of these students coming into the area, we've been working very closely with the colleges and universities to educate them, and by and large, they get it. These are institutions of higher learning. They understand the gravity of what they're about to undertake. So they are not taking this lightly, but does it give me concern? Absolutely. We've got to follow this very, very closely.
Thank you.
Okay, well, with that, I will end our conference, and thank you all, as I always do, for all of your time and your dedication to covering these important topics. And I look forward to talking again. Thanks very much. Have a good afternoon.